Here are my disclosures. So I wanted to start out, it told me to talk about what radiation therapy is like and the sort of nuts and bolts. So I wanted to start out with an accurate depiction of an average day in clinic. As you can see, there's me on the left and delivering radiotherapy. On the right is one of my physicists I work with quite a bit, Michelle Kim, helping to keep me honest as we sort of think about how we apply radiation for this difficult disease. So in radiation therapy, we have control of space and time, which sounds a lot cooler than it really is. Essentially, spatially, what we do is we try to conform the radiation to the target, put more where I want and less where I don't. And temporally, we try to spread the dose out in a way that allows us to more selectively target cancer cells. And this is typically done by fractionation, where you give some amount each day. And obviously outside the scope of this meeting, we're working on some pretty novel and exciting ways to look at dose rate, which I hope to be able to talk about when we have more results in humans. However, as pointed out by Michelle repeatedly to me, they're the laws of physics, they're not suggestions. And so we sort of ended up in this difficult position. Radiation is extremely effective at treating mesothelioma, but even with the best modalities that we have available, I cannot treat the entire pleura, I can't treat the entire peritoneum safely. So thinking about the different modalities that we have, and I guess what I'd like to start with this is there is no best radiation. There's only where a tumor is, what I want to treat, and what the tools that I have available. And different modalities will do well in different scenarios. So here you can see what traditional 3D, so if you think about the radiation field, you can come from a couple different angles, you can shape it from the outside, and so in this case we're treating a lymph node area or a tumor that's near the center of the chest, and you can create a somewhat conformal dose around that area at the expense, with x-rays, of some normal tissue. So here the red is the highest dose, green is intermediate, and blue is sort of a low dose. If I get really fancy, and you can see here, instead of just shaping a little bit of the field, what if I use this dynamic MLC? And so the idea here is this can actually move to shape the beam while the gantry is turning, and I can get really fancy in the various words for this. We probably have more different acronyms than patients treated at this point, but this is IMRT or VMAT type technology, and essentially I get better conformality, but you see what happens. Now, instead of having this somewhat intermediate and a little bit of low, I get probably a little bit more intermediate and a bunch more low dose. If I want to get really, really accurate to treat small areas, and this has become very commonplace now, I can treat spinal metastases and miss the spinal cord. We can treat lung metastases and miss the other stuff. We can treat a liver met and miss the rest of the liver. But you can see again, when I sort of show you the actual dose being deposited, all of this conformality comes at the expense of a low dose wash. And so that's because x-rays have exit dose. So you think to yourself, okay, well, why don't I use a kind of radiation that doesn't have exit dose? And that's essentially what protons do. So when you have protons, you have a cyclotron or synchrotron or cyclosynchrotron or some sort of accelerator. The beam comes out. We control the depth of penetration of this beam by controlling the energy, and then we can use magnets to scan it. And so what does that look like? Thinking about this particular volume being cut up into little bits, we can basically scan each layer with a new kind of energy and create these highly conformal dose distributions that have no exit dose and limited entrance dose. So what does that look like in space? Here's that same patient with 3D. Here's what IMRT might look like. And here's protons. So you can get this very nice dose distribution that can be very conformal, but again, no best form of radiation. Everything has drawbacks. You'll see what happens here, because I don't know where this is in time and space, I kind of have to overpaint it in case it's moving as the patient's breathing, and that creates this sort of extra horn of radiation that kind of goes off. So under certain circumstances, it's less beneficial. In that patient, say, with the liver metastasis, now you can see I can make a highly conformal dose that actually is very nicely sparing all of that normal tissue. So it's unequivocally going to be better in that case. One of the things that we suffer with in radiation is this great paradox, which is the bigger the area I want to treat, the lower the dose effectively I have to use, and the longer it takes to treat. And I think anyone who's had radiation, certainly any of my patients, when I talk about doing 6 to 7 weeks every day, and I usually get a very crestfallen look, and every day, and I'm like, well, if you say every day, it sounds better. 7 weeks is a really long time to come in for radiation every single day, even if it's only 10 or 20 minutes. And not only do I have to slow it down a bunch to treat this bigger area, I end up using a potentially less effective dose. If I'm treating a very small area, I can use that same 70 gray, I can partition into 1, 2, 3, 4, 5, treatments that are quick and easy. And that's essentially the teeny-weeny living space that we live in. And you'll notice when I show, say, something like the whole pleura, I'm treating the external part of the pleura. I cannot go in and treat the fissures, and we'll see that in a moment. In terms of other things that we do to control the dose, it turns out patients breathe. A lot of people don't know that, but yeah, it's definitely conducive. So we need to minimize respiratory motion. Things move around a lot. And in fact, a lot of patients are very interested in getting proton radiotherapy. And the simple way that I put it about protons being better or worse, if you were a block of wood, where I would know exactly what you were made of, and I could precisely locate the tumor within that, and it never moved, and I could accurately position it on a daily basis perfectly, protons would always be better. And to the extent that you breathe, things move. When you think about the lungs or the peritoneum, you have gas bubbles, you have the lungs changing, you have the heart beating, and you have all of this motion we deal with. So one of the things we can do is simply apply what one of my patients referred to as a scientific boa constrictor. So we can actually compress the abdomen and reduce respiratory excursion and sort of force the body to breathe more through the ribs. Or we can even use a scuba mask-like device that allows us to have you hold your breath during the radiation. Using all of the technology, we can incorporate biologic information with PET-CT. We use a lot of radioactive sugar type PET-CTs, but there are now a whole variety of novel types of PET that are being developed that may allow us to more accurately target the highest risk areas of tumor that might come back. We can do this in both space and time. We can incorporate MRI, and we can incorporate all of these other modalities. But at the end of the day, we create a dose, or we create a map of where we want the radiation, all of the normal tissues around it, and how you can see here in this sort of movie loop during, not much of a movie loop. All right, so this is moving in space and time. There we go. We can see it like moving a little bit with breathing. All right, so enough physics. What do we do with treatment? So with pleural mesothelioma, again, we treat a number of different types of patients. Primarily, we do a lot of treatment of things like isolated recurrence or isolated areas that are causing pain or compression or problems. So, for example, here's an anterior mediastinal recurrent mass that's growing on top of the heart. Very difficult to deal with surgically. It's growing on systemic therapy, and we're able to very nicely treat this and miss most of the other tissues. Other cases that we do some of, that's a little bit more elegant, is the idea of treating the entire external pleura, but you'll notice again, I can miss the lung with protons and some very fancy technology, but I cannot treat those fissures that go between the lungs, because if you do that, you're going to overdose the lung. What does this look like with protons versus photons? So sometimes protons can be dramatically beneficial, as in this patient, or this particular patient, for those of you aficionados of anatomy, this is a kidney, and you'll notice what's missing on this side. This is a patient who congenitally only has one kidney, had a recurrence of his mesothelioma, and we're able to treat his entire pleura using protons and have 0 dose to the kidney. In the peritoneum, one of the things that we suffer from is that the space is just so much more convoluted. So the peritoneum covers each organ specifically and then covers the whole outside, and that becomes extremely difficult. In the old days, maybe 30 years ago, before chemo and immunotherapy got better and surgical techniques improved, we used to think about treating whole abdomen, and you know, some of you may have heard about this in the past, where we treat the entire abdomen and we'll actually, with a very large field that's pretty unsophisticated, and will block the dose to the kidneys. This really isn't done anymore. It's just too toxic. So in the peritoneum, most of the time we're spot welding. So for example, this is a patient who'd had multiple surgeries, who had a recurrence in the peritoneum right outside the liver that was invading in the liver, causing pain, and both being the only site of progression. I'm able to treat that while she stays on her immunotherapy. The other sort of, and this kind of brings up this idea that we call the oligometastatic paradigm. So this is, we have this ability to treat these very small areas in a couple of treatments, maybe up to 5 total treatments, so it's not too much of a drag to come in with pretty minimal symptoms. And when you think about cancer, it's a clonal disease, so you can have one area seeded by a tumor cell that's resistant to the current systemic therapy, that's growing, everything else is under control, or one area is growing and causing pain or compression or problems. And this is where we've really started to radiate a lot more patients in oncology now. So we can do these very conformal, either proton or photon-based techniques, and we can treat little deposits. And so one of my patients once called this radiation whack-a-mole. And again, what we can do with this, and this is actually the patient, over the course of about 7 years, he would have isolated recurrences, and each time I was able to treat fields, and it was in the very early days of proton radiotherapy, where my techniques are getting more sophisticated as his recurrences get more widespread, and we're able to actually keep him going for many additional years with 5 courses of radiotherapy, and he had almost no side effects whatsoever from it. So it can be very powerful under select circumstances. And then just to finish, and this is sort of the magical fairy dust of radiation, we know that immunotherapy works, and it can work when nothing else does. As I think you've heard from a lot of people, we're struggling to figure out whom it's the best to use in, what are the biomarkers that will tell us which patients are gonna have the best responses. One of the things that has to happen, though, most of the immunotherapies we're dealing with actually just take the brakes off the immune system and help you use a pre-existing immune response to attack that tumor. So most of them don't create a new immune response out of nothing. One of the things that radiation can do is to kill the tumor cells in a way that's very interesting to the immune system. So the idea is you kill the tumor cells with radiation, the immune system comes in to clean up the mess, and in doing so, learns about this tumor a little bit more, and we use immunotherapy then to take the brakes off the immune system, and we can see some very, very dramatic responses. So this is a patient very, very early on when we were just starting to use nivolumab immunotherapy, and you can see here, this is a tumor that was outside the radiation field. She was progressing. I radiated a little area that was causing pain, and we suddenly saw this incredible and persistent response in tumors well outside the radiation field for a drug that had previously not been working. This can be wonderful. One of the biggest difficulties we now struggle with is just it's very hard to make it happen on purpose, and just like a lot of the immunotherapy, we will use it and see what we can get, but again, it gives you sort of a little extra hope sometimes when you get radiotherapy that your systemic therapy is going to start working quite a bit better. And I guess with that, I will stop and ask for questions. And please don't tell my daughter I use this, because she's 17, and but it's perfect. Anyway, thank you.
Any questions?
Just curious about side effects with the radiation.
So everyone gets a little bit of tiredness from radiation. That's sort of a universal side effect no matter where we treat. Bigger area, more tiredness. And then most of the other stuff from a side effect, if you think about it's all local to where we treat, there's acute side effects that might happen during the radiation or for the first few weeks or months afterwards, and those are all inflammatory. So inflammation of the area, so like for example, if we treat near the esophagus, the swallowing tube, you can get sore swallowing. If we treat the lung, you can get a bit of a cough from inflammation in the lung. And then most of that settles down or might be treatable with steroids or those sorts of drugs. And then the long-term side effects that might occur years later are typically scar tissue related, where we have scar tissue developing in the lung that makes it less effective at breathing, or scar tissue developing. And that's one of the reasons why we don't use it in the peritoneum anymore, because A, we can't get a high enough dose to really fully control meso, and B, 15 years later, you're dealing with severe liver or gastrointestinal or kidney complications.
You're right on.
Oh, one more? Oh.
Just have a question. If you have isolated spots and you would like to make a decision between proton radiation and cryoablation, which would you take?
So that's a difficult one. So you can, instead of doing radiation, you can go in with an external probe and either use heat or freezing to kill the tumor. What we have typically done is we prefer radiation where we can, or where it's fits well into the treatment paradigm, and we reserve the cryoablation and heat ablation for patients who've either failed radiation or don't want it. So for example, I have a patient we just saw back in clinic again. She's 8 or 9 years out from surgery with a recurrence in her chest wall, but I'd already radiated her once post-op, and she had breast cancer radiation 25, 30 years ago, and the area is right between those fields. So that was a great case. We referred her to the interventional people to do it. When you got a hammer, everything looks like a nail. I tend to prefer radiation just because it's sort of got a better, longer track record, but for certain locations, cryo can certainly help. Well, thank you very much.